My low point probably came in some of the conversations where my wife was expressing how unsatisfied she was with our sex life.
I felt like I had failed in being intimate, and it was devastating.
He was desperate to find something, a cure.
It was really embarrassing for me to where a lot of times I just, I gave up.
Erectile dysfunction affects the psyche of a man more than anything else.
People think that they're the only one, that they're alone, that there might not be a solution for their problem.
52% of men between the ages of 40 and 70 have some degree of erectile dysfunction.
ED is the tip of an iceberg. It translates into all aspects of their life. So it's our duty to raise awareness, demystify, educate about a solution that may be the single best treatment option beyond the pill.
If you could put yourself in my shoes and say, what was it like? And then change it.
Maybe we wouldn't have wasted so many years.
The reality is you can fix erectile dysfunction and you can have a life, a good life.
Good evening, everyone, and thank you for joining our Men's Health webinar. We'll start with a few housekeeping items, and then I'll introduce our speaker. First, your attendance tonight is completely anonymous to other attendees. No one can see your face or your name, and any comments or questions can only be seen by myself and our speaker. If you wish to ask a question, please type it in the chat box at the lower part of your screen, and all questions will be answered at the end of the presentation. Our presentation tonight will last for approximately 45 minutes and will be presented by Dr. Cara O'Brien from Mid-Atlantic Urology, followed by our patient champion, Ron, who will share his story with erectile dysfunction. With that being said, we'll start off tonight's webinar discussing the signs, symptoms, and treatment options for erectile dysfunction. Dr. O'Brien, I will turn it over to you.
Thank you so much. Welcome, everyone. I'm really excited to talk with you tonight, give you really a bird's eye, 30,000 foot view of erectile dysfunction, and sort of pique your interest, give you some thought-provoking topics to then go meet with your urologist and ask some really, really great questions and find solutions that may be helpful for you. Just briefly, here's a little bit about me. I grew up, born and raised in Virginia, did my schooling down there, and then came up here for residency at the University of Pennsylvania. And here I am, still in Philadelphia over a decade later. So my office is in Media, Pennsylvania, accepting new patients, and would be delighted to talk to anyone else about further questions regarding today. All right, let's start with a little bit of background, a little sort of understanding explanation of erectile dysfunction. I think this can be helpful to know the statistics. Like that video said, you're not alone. This is an incredibly common condition that affects many, many men. It is defined as the persistent inability to achieve or maintain an erection that is firm enough to perform sexual intercourse that is satisfying to the patient and his partner. So how common is it? Well, like we said, it's pretty darn common. 1 in 5 men, 20 or older, suffers from some degree of erectile dysfunction. It's estimated that more than half of men over the age of 40 report some degree of erectile dysfunction. So those are big numbers. Just briefly, a little bit of physiology, anatomy about how the erection process works, because this is actually very complicated. And this is something I talk to patients a lot about, kind of understanding the sexual process. What is the difference between an erection, an orgasm, an ejaculation? These are all very separate, unique processes. And so that can really help in counseling in the office when we're talking about which treatment is right for you, what are your goals, what are your goals with your partner. So just quickly to give you a little bit of, like I said, the physiology of how the erection process works. So with arousal, whether that's visual or usually tactile, touching, stimulation, the nerves around the penis become activated. That activation allows muscles to relax. The relaxation of the muscles allows blood flow into the vessels of the penis. More and more blood flow creates a more firmer, stiff erection. So there's two parts to it. There's the blood flow causing the stiff penis. And then with that increase in blood flow, that expanding of the blood vessels closes off the veins, which then prevents the erection from going down. So two steps, the engorgement, and then with that engorgement with the blood flow, the closing of the veins to keep the blood flow in there and maintain the erection. All right. So what are some causes of erectile dysfunction, or what do we see as other conditions that are associated with erectile dysfunction? There are a lot of them. Just a few here. Age. As we get older, this happens. Like we said, we see it more often in our older patients. Those men over 40, over 50% are reporting some form of erectile dysfunction or dissatisfaction. All the things as doctors harp about, not smoking, keeping a healthy weight, an active lifestyle. We know that smoking, we know that diabetes, we know that high blood pressure, we know that issues with high cholesterol are very common and associated with erectile dysfunction. Other things, depression, anxiety, we'll talk about these a little bit more specifically. There are just so many things can contribute to sexual health overall. So another reason it's really important to kind of sit down with your urologist, your primary doctor, and hash out what of these applies to you and what can we start, what are the first things we can do to kind of get you back in the game. The pie graph over here on the one side just sort of gives a sense, vascular causes of erectile dysfunction. So those are more like high blood pressure, heart disease, things like that, diabetes we see, and then medications as well. So there are many medications that are associated with erectile dysfunction or a worsening in sort of potency for men. So other things, again, to discuss. And then there's less common things, those men who have undergone pelvic surgery, had any sort of trauma to the pelvis, neurological causes, endocrine. It's not just a medical issue, okay? That's another thing that I'm going to harp about over and over again. It's a medical issue, but it also really, really affects patient relationships, patient satisfaction. So let's kind of get into these a little bit more specifically. So psychological effects, the impact, there's no potential impact of it. There is a true impact of erectile dysfunction on psychological state. And it becomes kind of this vicious cycle, this snowball effect, that anxiety, depression, low self-esteem, self-confidence, those can actually cause erectile dysfunction. And then it snowballs in that men become more anxious, more depressed, have worsening self-confidence because of those erectile issues. So this is really something that I like to talk a lot with my patients about. I think that's a really important aspect of this. And it leads to these downstream effects of emotional and physical withdrawal from between patients and their partners. So very, very important to address kind of the psychological causes, but then also the psychological side effects or impact that erectile dysfunction can have on the patient and the patient relationships. All right, so we mentioned diabetes, 30% or so of erectile dysfunction associated with diabetes. Here, this graph is saying half of men with diabetes have sexual troubles. So again, incredibly common. We see this all of the time in the clinic. What also is kind of a drawback of diabetes is that patients with particularly poorly controlled diabetes may be less responsive to the oral treatments, the pills we have for erectile dysfunction. And interestingly, we see that erectile dysfunction can be an initial presenting symptom of diabetes. So maybe a man hasn't been officially diagnosed, but that's certainly something that we want to look into if erectile dysfunction is occurring. So kind of a little bit again of the pathophysiology of how diabetes can cause erectile dysfunction. So we know erectile dysfunction is common as men age, but diabetes can make it worse. And that's really because of the impact that dysregulated blood glucose or blood sugars can have on the blood vessels, but also the nerves. And remember, we said that the nerves need to be stimulated to induce the erection process. And then those blood vessels need to be able to engorge. So we're getting kind of a two-hit here with diabetes. The erectile dysfunction medications that we have require some stimulation from nerves. So we have to have some good intact nerve sensation to create that stimulation to then create the blood vessel or the engorgement process. So this is one reason in some of our diabetic patients that the medications just don't work as well as we would like. So again, factors that can sort of run together or increase ED in men who have diabetes: age. We know age in and of itself is a cause of erectile dysfunction. So add age to diabetes, no brainer that that's going to be a concern. The other thing is how long you've had diabetes and how poorly your blood sugars are being controlled. So keeping in mind, really helpful to have good hemoglobin A1C maintenance or good numbers. And that's something I always ask guys, hey, what's your hemoglobin A1C? Partly because I want to see kind of how involved in their health are they? Do they even know what their hemoglobin A1C is? And then, how well are we really controlling your diabetes? And is that one other way we can improve your erections? And then vascular disease, again, we said blood flow is important. So if you've got diabetes, it can be affecting your blood vessels. And then if you also have a vascular problem on top of that, not great. Diuretic treatment. So that's, something we see. We talked about medications being a potential cause of erectile dysfunction. So again, kind of just echoing, there are other pharmacologic or drug side effects that can lead to erectile dysfunction. And then heart disease. This is kind of similar to the idea of just poor blood flow, the heart not working the way it should, not pumping, and how that can affect it. Some phantom slide movement here. So let me keep moving along. Erectile dysfunction and heart disease. So some of this is pretty repetitive. We're hitting on it a couple of times here, but just to say that, again, heart disease and erectile dysfunction, oops, let me go back a little bit, are associated. And as we mentioned with diabetes, erectile dysfunction being kind of a first sign of diabetes, we also can see erectile dysfunction as being a first sign or symptom of heart disease. So again, when a man comes into my clinic to talk about erections, I'm always thinking in the back of my mind, diabetes, heart disease. What are other things that could be going on here that we are maybe not even aware of yet? So that's what symptoms of heart disease may develop within 2 to 3 years of living with ED. So again, is erectile dysfunction kind of the canary in the coal mine that is leading us to a need to work up a patient for heart disease? Erectile dysfunction is a risk factor for future heart-related events. The severity of ED is related to the severity of heart disease. And again, this is hitting on what I've said a few times here. ED actually precedes coronary artery disease in almost 70% of cases and could be a warning sign, as I said, a canary in the coal mine for developing heart disease or heart disease that hasn't been diagnosed yet. And so why is erectile dysfunction associated with heart disease? It gets right back to these blood vessels, this blood flow that I have talked about. Heart disease and erectile dysfunction are related. In fact, ED and heart disease are considered two signs of the same process, basically poor blood flow. The blood supply to the penis consists of small blood vessels, and when aroused, these blood vessels rapidly increase blood flow. Again, we saw that picture with our one of our first slides, the engorgement of the penis from blood flow into these small vessels. And if those blood vessels are blocked, if we're not able to get good flow, well, that's what can lead to not achieving an erection that is satisfactory. So what can we do to reduce risk? Again, harping on these things that we all know are important, but can be tough to fix in everyday life or address. So improving heart health, healthy lifestyle choices. We'll say it over and over again. I'm sure all of your doctors are encouraging you to do things like eating well, being physically active, keeping a healthy weight, limiting alcohol, limiting drugs, stop smoking. Yeah, that includes nicotine and marijuana. We know both of those can affect erections. And then taking steps to reduce stress. Very important. We talked about, again, stress, anxiety, depression can lead to not only lead to erectile dysfunction, but then kind of that snowball effect make everything worse. So I am always working on a team with the primary care doctor, always making sure my patients are doing regular checkups with their primary, with their cardiologist, with their endocrinologist, so that we can optimize health in all ways to then optimize erectile function. I just wanted to briefly talk about low testosterone and erectile dysfunction. Low testosterone is in of itself an entire other lecture, one I'd be delighted to give, but sort of just pertinent to this is that we do see that in men who have low testosterone, there are erectile consequences. So low T, you kind of probably have seen commercials for that, heard that term in the media, but low T occurs when a man's body produces less testosterone than normal. Low testosterone naturally occurs as men age, as men gain weight, as they develop poorly or less well-managed type 2 diabetes. Even sleep apnea can decrease a man's testosterone. And then chronic medical conditions, liver problems, HIV/AIDS also can be potential contributors to low T or low testosterone. And so we need to be aware of this link, this relationship. Other things other than erectile dysfunction that men may complain about or be concerned or notice that can indicate low testosterone, reduced sex drive. So low libido. A lot of men come in and say, I'm just not as interested in sex as I was. I don't know why. Something just feels different about this. And so that's a big one I hear a lot. Decreased sex drive, decreased libido. You can also see loss of hair in the pubic area and the armpits, testicles that are starting to shrink. Hot flashes. There's something called azoospermia, which is low sperm count we see in men who are actually getting fertility testing. Other things I hear commonly in the clinic are issues with depressions, issues with concentration and memory, brain fog, something I hear a lot. And then decrease in muscle strength and mass. I'm going to the gym, but I just don't have the energy, the endurance that I used to, and I'm just not building muscle, I'm losing muscle, all signs that trigger need to investigate further. Is there a testosterone issue? And that can be easily done with just a few blood tests to confirm if that is going on. And that's just another way we can try to address the erectile dysfunction concerns as well as all of those other symptoms. There are lots of options for testosterone therapy. There used to not be this many. The ones most commonly we use are injections or a gel that is placed on the shoulders in the morning. But there's also patches, there's little implants, there are oral medications now that are really safe. So lots of good options for us. And again, this is a whole nother talk on its own, but that's just, again, really hitting the high points. All right, so erectile dysfunction and prostate cancer. So how are these connected? Well, incredibly common for me to see patients after prostate surgery for prostate cancer with erectile issues. There are nerve sparing procedures. So this is, again, a whole topic in and of itself, but talking about prostate cancer surgeries, we can do a surgery that attempts to spare the nerves involved in erections. Even with best attempts at nerve sparing, there are many men who continue to have erectile dysfunction, who develop post-operative erectile dysfunction. We used to tell men, wait a year, see how it goes. If it's not better in a year, let's talk about surgical treatments. Now we're really saying 6 months. If things are not back by 6 months, let's get this ball rolling as far as what can we do next. So the nerves and some of the blood vessels that supply blood to the penis for an erection are very close to the prostate. And that's what I'm talking about, nerve sparing. So those erectile nerves that are sitting near the prostate, can we preserve those in some of our cancer treatments? We try. They may be injured though during prostate cancer surgeries or prostate cancer treatment, like radiation as well. So prostate cancer treatments can affect a man's ability to achieve an erection on a temporary or permanent basis. Like I said, we usually give it about 6 months to see how things recover and then decide this is probably not going to improve much more. So if the ED persists, then we go to more aggressive treatment options. This is sort of a helpful diagram, for those men who have undergone a prostatectomy for prostate cancer. You can just sort of see here's your prostate sitting here. What happens is it gets completely removed, and then this part of the tube, the urethra, gets reconnected or anastomosed to the bladder. And there are, like we said, lots of nerves and blood vessels sitting in this area, which can be affected or involved. So sexual dysfunction after prostate cancer treatment, whether that's radiation or prostate cancer surgery, there are options for management afterwards. 25 to 75% of men who have had a nerve-sparing radical prostatectomy for prostate cancer will experience erectile dysfunction afterward. There are a lot of factors that go into this. 25 to 75 is a huge range, but that's just because there are so many factors that can play into this, including whether what a man's erectile function was prior to the surgery, just in general recover, all sorts of things. But it is incredibly common. And again, as we're saying, even with nerve-sparing surgeries, ED may persist for a year or more after surgery. All right, Peyronie's disease. So what is Peyronie's disease and how is this associated with erectile dysfunction? So Peyronie's disease is a condition where a bit of scar tissue or plaque builds up on the penis and sort of inside the bodies of the penis, which can lead to a curved or bent penis, which is noticeable most commonly or most dramatically during an erection. It's not a bad thing per se. It's benign, I should say, meaning it's not a cancer, it's not a tumor, but it can affect curvature to a degree that is affecting sexual function, that is affecting penetration. And so patients may experience inflammation or pain, discomfort during erections because of this plaque or this bit of scar tissue. And there are thankfully options for Peyronie's disease. There are oral medications, there are injectable medications directly into the plaque buildup. There are surgical management options to remove the plaque and straighten the penis. All of these really depend on the degree of curvature that a man has and sort of what therapy he is willing or interested in undergoing. That being said, penile implants are also a large part or play a large part in management in men who have both Peyronie's disease and erectile dysfunction. So just to go over that, what should a man who has erectile dysfunction and penile curvature know about an implant surgery? Well, penile implants are great options for men who are struggling with both. And during the procedure for the Peyronie's or for the implant, we can do both use a penile implant, but also then address the Peyronie's curvature. So important to mention to your doctor if that is something that is of concern to you, so that we can try to troubleshoot and address both of them. All right, let's get into the good stuff. What are our options for treatment of erectile dysfunction? So lots of doctors are involved in this. The primary, I would call your PCP, your primary care provider, they have a good understanding of these basic medications. Viagra, Cialis, these have been around for a while. We know they're safe. Most primary doctors feel very comfortable at least starting a man on them. So certainly worth reaching out to your primary doctor, but then obviously a urologist. I mean, this is our bread and butter that we talk about and deal with every day. And really we can give you the whole host, the whole gamut of treatment options right up front. A urologist, a doctor who has specialized training that focuses on the surgical and medical diseases of the male and female urinary tract symptoms and the male reproductive organs. And then there are urologists who, do these sort of implant surgeries a lot, who have specialized training in it and really deal with kind of some of the more complicated issues that arise with implant surgeries. So, briefly all about all of these because they really deserve each of them hours to go over, but very, very simply, and kind of in this order, we talk about oral medications, pills. We've all heard of the little blue pill, of Viagra. The other commonly prescribed one is Cialis. There are different mechanisms of action or at least pharmacokinetics of those drugs to talk about with your doctor and different ways they can be prescribed. There are vacuum erection devices that allow an erection or encourage an erection. There is injection therapy, so something that we call intracavernosal injections. It's taking a really small needle and directly injecting a medicine right into the penis, gives you an erection within a couple of minutes that should last long enough for hopefully a sexual or a satisfactory sexual experience. And then kind of our last treatment option down the line, once we are not happy with these prior ones, is the penile implant. Okay, I talked about this quite a bit at the beginning of the course. The things that we can address kind of right off the bat that are going to be helpful in erectile dysfunction management. We always like to start with least invasive. So healthy lifestyle things, quitting smoking, losing weight, being more physically active, being more physically fit. Those things alone, honestly, I have seen help many men address their erectile concerns. And then the other component, again, I told you I really chat a lot about with my patients is sort of the psychological aspect of all of this, because it is a huge component to erectile dysfunction. And so it can be very useful, whether you're just talking to your urologist or your primary doctor, or even going for more, kind of in-depth sexual health, sexual therapy, couples therapy, to decrease the anxiety that's associated with all of this, with not only ED, but just intercourse in general and sex with partners, whether they be new partners or partners you've had for decades. So I think that is a really important aspect in our management of erectile dysfunction. So then, the first thing we go to after those psychological and lifestyle modifications are these oral pills, and the doctor word for them are PDE5 inhibitors. They're prescription medications need to be prescribed by a provider that can help improve blood flow to the penis. And so what I always tell men is this isn't a magic pill. You do need to, sexually stimulate yourself. Remember, we said those nerves are important in encouraging or instigating, initiating an erection. But with the assistance of these medications, we can increase blood flow and hopefully improve on erectile function. Common side effects I hear from men: headache, flushing, getting kind of a red face, feeling hot or warm, and then an upset stomach, so maybe heartburn, dyspepsia. There's a few reasons why we don't want to prescribe PDE5 inhibitors. They are in general incredibly safe, incredibly low risk of, serious complications or interactions with other medications. But again, always something to mention to your doctor. And this is why, your providers and not necessarily the internet should be prescribing these medications for you. Little statistic here. In a study of nearly 20,000 men with ED, men with diabetes were 1.5 to 2 times more likely to move on to other treatments, such as pumps and penile implants, compared to men without diabetes. And that's, again, because of the things we said at the beginning of the talk about the side effects or the consequences of diabetes. Vacuum erection devices. I can't help but think of the Austin Powers movie when I see these devices, but they're actually very helpful and very useful, and can be used as an adjunct. So we can do oral medications and a vacuum. So this doesn't have to be just on its own. What is it? Plastic tube you place over the penis. You use this pump to inflate, and it's used to create a vacuum that pulls or draws blood into the penis to create that engorgement. Once the erection is achieved, there's a little ring, an elastic tension ring that goes at the base of the penis, which then helps hold in the blood, trap the blood to allow you to maintain that erection. Common side effects are common things we see, some issues with ejaculation, with fluid emission, with orgasm. Bruising is probably one of the most common ones. Pain, penile numbness or coldness. Occasionally we hear that, but that usually is just really good counseling with the man about not leaving the ring on too long, and how to use a vacuum device. And like any treatment, if you're not getting a good effect from it, or it's uncomfortable, it hurts, you're going to be less likely to continue with it. The intracavernosal injection therapy, so ICI as we call it in the biz. So with injection therapy, a needle is used, and this is a really small needle. I don't know if you've ever seen a diabetes needle, but they're really tiny needles that is used to inject the medication directly into the penis. The medication acts quickly right in the area where we want it. It allows blood to flow into the penis. You get an erection, like I mentioned, within minutes. Side effects, as you can imagine: discomfort. A prolonged erection is kind of the most serious side effect that we really caution or educate men about. The other thing that we commonly, or I shouldn't say commonly, but we do see with this is that men who are using this for a long amount of time, or who are injecting the same site, they will develop scar tissue there, which can cause, again, some of that curvature of the penis. So important to get good training and counseling on how to use these injection therapies if you're starting those. And then the other thing would be a blood collection under the skin at the injection site. What's that? A bruise or hematoma just from the needle poke. Reasons guys stop this? Well, it's not sexy. It can be tough to be spontaneous. It can be kind of, like I said, unsexy to have to give yourself an injection before sexual intercourse. The other thing is cost. These are usually done through a compounding pharmacy, and so a lot of times it's out of pocket, which can be challenging. Many studies have shown that withdrawal rates are relatively high with injection therapy patients, and I would confirm that just in everyday life as well. All right, so getting to the penile implant. So what is this? It's a device that's implanted into the penis. It's intended to allow a man with erectile dysfunction to obtain an erection. The device is entirely contained within the body. So important, no one sees it, no one necessarily knows you have it unless you're talking with them and sharing that with them. It's controlled by you, the man, the user, so that you can achieve an erection when you are interested. It's designed to allow for spontaneity. It's designed to maintain an erection as well for as long as it takes to complete that sexual experience. Like anything, there are side effects, potential complications that we always need to talk about, and which I take a lot of time to counsel men about. Postoperative pain is one of them. Postoperative infection is one of the ones we worry about the most as surgeons. Those rates are relatively low. I think some of the larger studies were quoted as like 1 to 8% for significant infections. I think our more modern numbers now are like 0.5% to 3% risk of serious infection complications from these devices. The other possible thing is just a device malfunction, failure of the device to function, which can happen for a host of different reasons. And then the other thing is something called erosion, basically where the device erodes into an area that it's not supposed to be in. In a survey of men, 80 patients who received this specific AMS 700 penile implant, that's just a type of implant that we use, over 97% would recommend a penile implant to a friend. And those are numbers that I have seen repeated. Really satisfaction rates in the 90% for these type of implant devices, which is great, which is really, really nice to hear from patients who've been suffering from this for a while. Kind of just to give you a sense of things, and I have these devices in my office and let men and their partners touch and feel and experience them. The AMS 700, this is a 3-piece inflatable penile prosthesis. Why is it 3-piece? Well, here's the reservoir, here are the cylinders, and here is the pump. We have a little video that kind of explains all of this, but just to say that is what this inflatable penile prosthesis looks like. And then the other option is what's called a malleable prosthesis. So this one is really straightforward. You've got 2 cylinders that get placed in the penis, and there's not much else, to it. You're ready to go with an erection anytime you want. There's no pump, there's no complicated pieces involved. And so it's a good option. It's a nice option for some men. All right, AMS 700 inflatable penile implant. Dun, 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 dun. This has 3 design options, the most variations of any penile implant on the US market. And all of them are available with this technology called Inhibizone. Well, as you mentioned, one of the complications we worry about most as surgeons is infection rate. And so Inhibizone is this technology that is proven to reduce our surgical infection rates, but also to closely mimic this feeling of a natural erection. So it creates or provides rigidity when inflated, and then when it's deflated, it is flaccid, just like the sort of natural flaccid penis appearance. A lot of people think, oh my gosh, this must be, technology that, are you just started doing these last year? Well, no, penile implants have been around for a very long time, over 50 years, and hundreds of thousands of these have been placed in men around the country, around the world. All right, here is that video I was describing. Let's see if I can get it to play for us. So this right here is showing the man pumping, using the pump that is sitting within his scrotum to displace fluid from the reservoir, which is sitting up in the lower abdomen pelvic area, displacing fluid from the reservoir into the penis, and then deflating it, fluid goes back into the reservoir, and there's a flaccid penis. Kind of quick, but I think that gives at least some sense of how these work. And again, encourage you to come and touch and feel in the urology office to get a better sense of the equipment. Oh, looks like another video. Maybe we can see that again just to get a little better sense of things. Oh. All right, so here it is in an actual human body. So you see the man grasping the scrotum, grasping the pump that's sitting in the scrotum, stabilizing it with one hand, usually the non-dominant hand, and then squeezing the pump with the other. And as he squeezes it, he obtains an erection. So our goal is a nice straight erection that is satisfactory for penetration. And then here he is going to deflate the device. So again, he's stabilizing it with one hand and pressing on the device in a separate location to deflate it. That fluid is going out of the cylinders. He encourages that fluid to go out of the cylinders, and the penis is flaccid. Pretty neat, huh? All right. So what to expect? So implant procedures can be done either as an inpatient or an outpatient. It's really surgical or surgeon preference. So outpatient meaning you go home the same day versus inpatient where you would spend just the night, make sure you're feeling okay, pain control, sometimes a little extra antibiotics, kind of patient and surgeon dependent. Another thing that can be surgeon dependent is the type of penile implant that's chosen. I should say that is both surgeon and patient dependent, just kind of given anatomy and goals. But type of implant, the incision can also be located in different areas depending on how the surgeon prefers to do it and the patient anatomy. But all of the parts get inserted. It's performed under anesthesia. You are asleep. You are not feeling anything. You are not aware of anything. I really like my patients to take a few days, a week. I always say, listen to your body before you start doing any extensive physical activity. So I don't want you out chopping a cord of wood, the night after your surgery. It's your excuse not to mow the lawn, your excuse not to vacuum the house, get you sort of off of the chore list for a couple of weeks. And we really want you to wait a good 4 to 6 weeks before using the implant. I tell my patients 6 weeks and we start doing before using it. But we do start cycling it at about 4 weeks so that a man can start to get used to how the device works. Cost, coverage, these are questions that always come up in the office, and I kind of always say this is way above my pay grade. But just to say, commercial insurers may cover the diagnosis and medically necessary treatment of erectile dysfunction. Medicare has a national policy for ED, which includes penile implants, but coverage, it's always kind of dependent on a lot of different factors. We work with all of our patients. I have more trouble getting Viagra or oral pills covered than I do these implants. So it's kind of surprising, but usually we have very little issues once we kind of do the necessary paperwork, jump through all of their hoops in getting this covered. Financial assistance programs, I've had a few patients who have done that, which has also been helpful. So where there's a will, there's a way, and usually with a little bit of legwork, this is not a significant issue or impediment to surgical treatment. Just wanted to talk about benefits of this. Again, we're talking about the AMS 700 Boston Scientific penile implant, but just to say, because I think it is a good, it's nice to sort of see statistics about one type of implant. Again, 97% of patients would recommend one to a friend. 95% of patients report a improved satisfaction with their sexual experience, sexual intercourse. It's the only implant on the market with that antibiotic inhibisome impregnated into the product, designed to reduce the risk of infection, which is one of the side effects or complications we're most worried about. Typically covered by insurance and/or Medicare, touched about that. Only implant on the market with Parylene, proven in published studies to mitigate cylinder fatigue and increase long-term durability. So again, we want this to last you as long as possible. And so it's good to know that we have technology that is helping that. It's designed to be a long-term treatment. There's really no turning back from a penile prosthesis. So, my goal is for you to not see me in the office as often after we do one of these implants. And what's nice is that really it's entirely contained inside the body. Like we said, no one knows you have an implant unless you talk with them, share with them that fact. It is designed to feel natural. And that's one of the big things men talk about with these inflatable penile prostheses, is that they want that natural, flaccid to erect penile experience. Typically does not interfere with ejaculation or orgasm. And again, this is something to just talk more about with your doctor about, kind of understanding these different processes of erections, ejaculations, orgasms. How are these different? How are these tied in together? And it can increase spontaneity. You're not sitting around waiting for that Viagra to kick in. You're inflating your pump and going to plan B, whatever that is for you. So it allows you to be intimate wherever you are. You're not carrying your injection medications through the airport. You're not forgetting your pills at home. It's with you whenever you need to use it. There's risk to everything. And this is an important part about being a doctor, a surgeon, counseling men on risks. So with any surgery, with any treatment, no matter what we're doing, and not all patients are candidates for an implant. So these are things we need to talk about. Are there reasons why this isn't a good option for you? Are there other options that may be better, at least to even start with? A couple of things just to hit again on a sort of 30,000 foot view about risks. Will make natural or spontaneous erections, as well as other interventional treatment options, impossible. So again, if we do a penile prosthesis, there's no turning back. There's no trying Viagra again to see if that will help. Device malfunction and failure we talked about, which can lead to potentially additional surgeries. Device migration, that's when that device erodes or wiggles into an area where it's not supposed to be. In men who have these, also sort of this, again, sort of same idea of the device migrating or eroding into an area it's not supposed to be. And then infection. And there can be this thing called sort of an auto deflation, an unintended inflation of the device. That can sometimes happen in men. And then pain and soreness. That's with anything post-operative. But in general, that improves or goes away with the healing process. All right. So we talked about erectile dysfunction affects a lot of men. You're not alone. There's lots of treatment options. We're all happy to sit down and talk with you about them. Here's a website that can be helpful if you wanted to learn more.